Our last speaker is Connie. She's the PI of the Partners PrEP study, and she's Professor of Medicine and Global Health at the University of Washington in Seattle.
Thank you. So these data are only a month old, so as you'll see, there's some data that are still pending. We conducted a 3-arm study with the desire to, in the same population, directly compare tenofovir and emtricitabine tenofovir to a common placebo arm in HIV serodiscordant couples in which one partner had HIV and the other did not, and the HIV positive partner was not eligible for ART based on national guidelines in Kenya and Uganda. So we conducted this in 9 sites, 9 fabulous sites in Uganda and Kenya that half of them were new to research and just did an amazing job. The study procedures are basically very much the same as all the other PrEP trials you've heard about. And what's different about our trials that we did do prospective follow-up with the HIV-infected partners, which included quarterly visits with 6 monthly CD4 counts, ongoing HIV care, and referral for ART when they met national guidelines. And all the couples received both individual and couples counseling as well as condom promotion. Uncircumcised HIV-negative men were referred for male circumcision, and they were screened and treated for STI. The population was 2/3 almost of the couples involved HIV-negative men. So this is the only PrEP study that includes, other than the TDF2 study, that includes a large number of heterosexual men. The couples were, the average age was 33, almost 98% were married. These were stable couples who, at enrollment, had stated that they intended to stay together. Although the duration of partnership was 7 years, they had only known that they were serodiscordant for less than 6 months. The HIV-infected partners had a median CD4 count of almost 500, and the plasma viral load was close to 4 logs. And during follow-up, about 20% of the HIV-positive partners started ART. The couples were incredibly motivated. Our retention throughout the study was 95%. Our primary measure of adherence was monthly pill counts of unused study product, and was quite high with almost 97%. We had a presentation at CROI where we did ancillary studies using unannounced home visits and MEMS caps, which really confirmed this level of adherence in the 3 sites that participated. Our DSMB held an interim DSMB meeting to review efficacy on July 11th and advised us to stop the placebo arm and make the results public based on review of 90 events, 78 of which contributed to the modified intent to treat analysis. There were 12 infections that occurred at enrollment prior to randomization, 3 in the tenofovir arm, 3 in the emtricitabine tenofovir arm, and 6 in the placebo arm. So among the 78 events in the primary analysis for the modified intent to treat analysis, we had 18 in the tenofovir arm, 13 in the emtricitabine tenofovir arm, and 47 in the placebo arm, for an estimated efficacy of 62% for tenofovir with a confidence bounds of 34 to 78%, 73% in the emtricitabine tenofovir arm for 73% efficacy with confidence bounds of 49 to 85%. There was not a statistically significant difference in efficacy between tenofovir and emtricitabine tenofovir. In terms of safety, there were no statistically significant differences in deaths, SAEs, or key laboratory AEs by arm. As you can see, there were a total of 24 deaths in the population, and none of these were considered related to study products. Many were related to trauma and acute medical events. Among the SAEs, many of those were laboratory defined. Of the medical ones, they were primarily malaria and trauma. As you can see, there was no difference by arm, as well as no difference by arm in confirmed creatinine adverse events, which were 1% across the whole study population, or confirmed phosphorus SAEs. In terms of tolerability, we administered a monthly 19-item symptom questionnaire, just highlighting the small differences that we did see were in GI tolerability with nausea and primarily diarrhea at the first month, but very small differences. In terms of pregnancy, among the almost 1,800 HIV-negative pregnant women, we had a total of 272 pregnancies. Many of these women are still pregnant, so I'm not going to be presenting infant data yet. We're still obviously following them, and we'll eventually be able to report on that. There was no difference in pregnancy incidence by arm, which was overall 10% among the HIV-negative women, and time off study drug due to pregnancy was 1.8% among the HIV-negative women. Sexual behavior at enrollment, now that they knew that they were discordant and had already received counseling about that, 27% of couples reported unprotected sex in the past month, and that proportion went down in all three arms during the follow-up period. We are analyzing the data on outside partners because we think that for couples it's not only an issue of condom use but also proportions who report outside partners. And from our prior herpes study and from HB1052, we do know that as people learn that they're serodiscordant, they do have outside partners, so this is an area we're still analyzing. The data that I cannot present because it's underway is our resistance data, our viral load, and the seroconverters and drug levels. All this is actively being tested. So in summary, we observed a 62 and 33% respectively reduced risk of HIV acquisition on tenofovir and tricytidine tenofovir in African HIV-negative men and women. And we announced these results last month at IS based on the interim DSMB review. The drugs were safe and well tolerated. We saw no evidence of risk compensation, and the study is continuing based on the DSMB recommendations in order to continue to gather comparative information on efficacy, safety, tolerability, and resistance with tenofovir and tricytidine tenofovir, and the placebo arm participants are being offered after PrEP. We are proposing demonstration projects. We're in discussions with our sponsor, the Bill and Melinda Gates Foundation, about this, to try to move from these results showing strong efficacy to look at the feasibility of targeting to the highest risk couples, as well as their willingness to take PrEP using monthly versus quarterly testing, adherence in a more real-world context where they'll have less frequent contact with clinic staff, risk perception, sexual risk behavior, and very importantly, fertility, and now that these efficacy data are known, as well as to acquire more information about pregnancy outcomes in a linked protocol. Just want to acknowledge the incredible work, particularly of my colleague, Dr. Jared Baton, who is co-chair of this protocol, and the many, many people in Seattle and the 9 sites, and our core contractors for data management lab, and the sponsorship from the Bill and Melinda Gates Foundation and the supply of drugs from Gilead. It was really a heroic effort and appreciative. Thank you.